So, hello, I'm John Hickman. I'm part of Consilium Scientific, and welcome to this webinar, which is one of a series addressing important topics in health policy, and here polygenic risk scores. We've got a very distinguished panel, and the chairman is going to be Ewan Birney, and he's going to introduce something about polygenic risk scores, and then there's going to be a discussion about I think whether they're useful and where they're useful. I'll turn it over to you, Ewan. Thank you very much.
Okay. And John, do you think we should wait for a little bit longer to make sure?
Well, we've got we're doing okay. We've got 24 so far.
I don't know what good looks like here. Wonderful. Okay, so I'm Ewan Birney. I'm Deputy Director General of EMBL, the European Molecular Biology Laboratory, and I'm a genomicist. I do many things, but I love my DNA. And just some setting for the people who haven't met polygenic risk scores. Human genetics, we've known for a long time that genetics is a component of many of our phenotypes that that make us individuals. And that genetics kind of comes, you can think of it often coming in two flavors. One flavor are rare, often very severe changes, and sometimes that means that people are very short or very tall. Sometimes it means they have rare diseases such as cystic fibrosis. There's another class of genetics broadly where we have far weaker effects for individual parts of the genome, the genetics, and yet when we look at the genome as a whole, we can see that there are many, many, many different parts of the genome that all contribute to a phenotype that we can measure. And that can be a phenotype such as height, so a very simple thing to measure, or something which is kind of the result of a very complex process. For example, whether you get diagnosed with type 2 diabetes, whether you meet the criteria for type 2 diabetes. And scientists over the last 20 years have made huge strides in our ability to measure the genome in cheaper and more complete ways over the years. And so it's now really quite cheap to measure the genome, and we'll have some of the speakers here talk about how that is panning out in the future. And then scientists and statisticians have become more and more sophisticated in how one can combine the action of many, many different places across the genome to make a single score, a single metric, which represents the genetic contribution to a phenotype, be it height or a particular disease. And we call those, different people call these things different things. One of them is polygenic scores or polygenic risk scores, so PRS or PGS, depending on some fine details of the science. And what we're going to talk about here is not only less the how do you make these scores. I think that's quite well settled, although there's many, many dramas in the details of that about how you make the scores, but more also how you use those scores. And you can use them for research topics, and you can use them in clinical practice, clinical research, and then heading towards clinical practice. And that is, many of the experts here come from that kind of continuum. So with that introduction, and I apologize for any mistakes I've made by the experts, you can correct me as we go around. What I've asked each of the experts here is to provide a very brief introduction to themselves and a little kind of opening statement so that you can understand where they're coming from. I'll then try and draw out some points of agreement or disagreement between the panel, and then go to you, the audience, for any questions, and do write them in the chat. I can be your voice, or you can unmute and ask them directly. We will finish promptly at 6 p.m. UK time, so that's in 55 minutes. So with that, I start with Claire. Claire, could you introduce yourself and give some your perspective on this area?
Thank you, Ewan. So my name is Claire Turnbull. I'm a clinical geneticist. So I see patients and families in clinic in whom their pattern of cancer looks to have an inherited basis, and test them for the type of high-risk genes that Ewan described firstly, so BRCA, Lynch syndrome, and so forth. I'm also a research geneticist, and over the last 15 years have conducted genome-wide association studies, finding the types of common variants that constitute the polygenic risk scores. And I also have a public health background, and I'm lead for genomics at the Faculty of Public Health. So sort of amalgamating those three perspectives, there's been quite a lot of hype and expectation over the last 10 years that polygenic scores will help us rationalize screening, will help us address the burden of common complex disease and meet our early detection targets. And I come from a perspective of trying to moderate those expectations. Common complex diseases are late onset. They only have quite modest heritability. And of that modest heritability, only a very small part is captured by a polygenic score. Ergo, a polygenic score is actually of quite limited predictiveness in terms of telling you much about their risk of disease beyond what you already knew from their population risk and their age. And I think the other blind spot for a lot of policymakers is a polygenic score will give you a little bit of dialing up and down on the risk. It doesn't in any way change how good the thing is that you are going to use to address that risk. So whether it's a screening or a drug or chemo prevention, so cholesterol drugs or whatever. So if you have a poor screening test that has problems, it will still have the same problems in a higher risk slice of the population. So problems with poor sensitivity and specificity for the screening test, like a PSA test, or problems with over-diagnosing good prognosis disease. Again, an issue with prostate screening. So just if you take a slice of the population who have a slightly higher prediction of risk incidence, it doesn't suddenly magically transform the tools that we have available to manage that risk. So I'm keen to modify and the hype and expectation around polygenic scores, because I think that is a problem in the policymakers in terms of their expectations.
Wonderful. And next up is Arun. Arun?
Hi, I'm Arun Ingrani. I'm Professor of Genetic Epidemiology at UCL in London, and I'm a consultant physician at University College Hospitals. So my main research interest is in the use of human genomics for drug target identification and validation, particularly using the Mendelian randomization principle. And this is a model that's largely been adopted by the pharmaceutical industry to prioritize research and development. But my presence here today is related to, I think, a recent piece of work which I've been involved in with colleagues, in which we sought to evaluate the performance of polygenic risk scores in population screening, individual risk prediction, and population risk stratification for hundreds of diseases using metrics reported in a catalogue of polygenic risk scores called the Polygenic Score Catalogue. And we recently published the findings in BMJ Medicine in October.
Thank you, Arun. Paul.
Good evening, everybody, or good morning from sunny California. I am Professor of Cancer Epidemiology in the Department of Computational Biomedicine at Cedars-Sinai Medical Centre these days, having been at the University of Cambridge for more years than I care to remember. I have had a long-standing interest in the genetic epidemiology of cancer, primarily breast and ovarian cancer, and I first wrote about polygenic risk prediction more than 20 years ago now. So I've been thinking about this for a very long time. And I have to say, I'm still not quite sure what my own opinion is, never mind what other people's opinions ought to be. It's a complex area. I think there's two issues. One, I kind of emphasize Claire's point that risk prediction is only useful in as much that you can manage risk once you've predicted it. And a lot of the debate is as much about what we do about the risk as identifying people at risk. And the second comment that I really think is important is that I think, genetics of common diseases has been extraordinarily successful in the last 15 years in identifying genetic variants that are associated with the risk of developing disease. Where genetics has been much less successful has been at identifying genetic variants that predict outcomes in individuals with disease. And that is the area where polygenic prediction really would perhaps have the most benefit, but we've actually not done very well at identifying such germline predictors of disease outcomes. And the examples I have are in cancer, where when I sort of wrote my first program grant over 20 years ago, I kind of thought that I was going to say we're going to find all sorts of variants associated with breast and ovarian cancer outcomes. And 20 years later, we've really found almost nothing in the common variant realm. So there's lots to discuss, but it's a very nuanced discussion.
Right, Rakib.
Thanks, Ewan. So, Raghib Ali, I'm a consultant in acute medicine at the University of Oxford and also a clinical epidemiologist at MRC Epidemiology Unit in Cambridge. But I'm here today in my role as CEO, Chief Medical Officer and Chief Investigator for Our Future Health, which I know we have an international audience, so not everyone may have heard of it. But Our Future Health is a relatively new health research program that's been established in the UK, and we launched last October. It has some similarities to a study that many of you would have heard of, UK Biobank, which I worked on myself many years ago, 20 years ago. But what we're trying to do in Our Future Health is to establish a resource which can be used to answer many research questions, both in terms of discovery, but also translational research. It's both an observational cohort, but also a platform for interventional studies and for discovery of new biomarkers, target development, target validation studies, etc. Since launching last year, about just over 1 million people have signed up to join the study. Our ultimate aim is to recruit 5 million people. Of those million, roughly half have given blood samples on whom we will be doing genotyping. And we will have the opportunity within Our Future Health to answer some of the research questions which we're discussing today and to establish the evidence base for both the clinical utility of polygenic risk scores in different diseases and also cost effectiveness in the longer term. So I hope it will be a useful resource. I've spent most of my career trying to establish these types of resources in populations that have not been studied previously, both in the UK and globally. And one of the key things we're trying to do in Our Future Health, and have had some success so far, is to ensure we have better representation of non-European ancestry ethnic groups. So we have about 150,000 people of non-European ancestry that have signed up so far, but also more deprived groups, so socioeconomically deprived groups, because of course all common chronic diseases are an interplay between social determinants, environmental determinants, as well as genetic susceptibility. And through Our Future, we're trying to get a comprehensive and detailed picture of all of those risk factors. And again, we have about 250,000 people from the more deprived third of the population that have already joined the study. So that's what we're trying to do, and I'm happy to come back when we get maybe into more of the details.
Great. Peter.
Thanks, Ewan, and thanks everyone for your interest. Just by way of background, for most of my career, I was in the academic world. Paul talked about the success we had in our field over the last 15 or 20 years in learning about the genetic basis of many of the common diseases. And I was very lucky as an academic to be right at the center of that period of incredibly exciting discovery. I realized at some point, though, that although as academics, we would often say, especially when we were asking for grant funding, we'd often talk about the impact this was going to have on people's health and healthcare. It wasn't having much impact. So almost 10 years ago, with colleagues in Oxford, I founded a company, and a little bit later, I left my academic role to become a chief executive of the company. The company is called Genomics PLC, and it's about trying to translate the incredible scientific advances we've had into things which can make a difference for people's health and in healthcare. And to go back to Ewan's introduction, we've known for many years that genetics is one of the important risk factors for all of the common diseases. We now have a way of capturing that via polygenic risk scores, it's only one risk factor. For many diseases, there are other very important risk factors. In lots of diseases, health systems already try and understand and estimate people's risk. If you go to your GP in the UK and you're a certain age, they'll run an algorithm that combines your sex, your age, your blood pressure, your BMI, your cholesterol level, a number of other factors to understand your risk for cardiovascular disease. So I think one of the first and important questions to ask when we think about the genetic component of risk via polygenic risk scores is, disease by disease, how would we think about using this in medicine, in practice? And in cases where clinicians are already estimating risk from other risk factors, is there a way we can include genetics, and can we be confident that we can do that in a way which is both equitable and improves risk? So that's the kind of first key question. And it's a setting where the details matter. You need to work out disease by disease exactly what would be the best way of using these tools. Second thing I think that's really important is it practicable? Doctors in general and in the UK are very stretched currently. So it's really important that this fits in with current workflows. It doesn't swamp the clinicians or the hospitals. And the third absolutely critical question is it cost effective? If it costs money to do this risk prediction, do we get the benefits back in terms of improved health, in terms of savings to health systems in the right way, and so on? So they're kind of three key questions, and I hope they can be part of our thinking tonight. And just to say, in terms of what we've done in the company, in Genomics PLC, we're honoured and privileged to be working with Our Future Health. As Rahib was saying, one part of that is to understand people's genetic risk via polygenic risk scores, and the project plans over time to feed back some of those risk scores to individuals. Genomics, our company, will be providing the risk scores that get fed back to people in the UK. So that's a really exciting opportunity, and actually a credit to Rahib and his colleagues, something that's globally leading. And the other brief final comment, and I'm happy to discuss it more, is in terms of does this work, we actually ran a trial with GPs in the NHS where we combined the genetic component of risk with all the other risk factors they currently use for heart disease and stroke. It's in the process of being published. We presented it at conferences. Short version is that was quite successful. So we've learned quite a lot about how this works in practice in at least one setting. Thanks.
That's great. And last but not least, Annika.
Yeah, thanks, Ewan. Good evening. My name is Annika Lukeson. I am a professor of genomic medicine at the University of Oxford, and I'm also a clinician like Claire. I'm a clinical geneticist who sees families who want to know about their risk of developing various genetic conditions. And my research group is very interested in the ethical, legal, and social implications of translating genetic technologies into practice. So my interest in polygenic risk scores is how can we have more realistic expectations of what they can deliver, because despite the best explanations and detailed descriptions of polygenic risk scores, I think what still often happens is that people hear something that has a genetic component in it as being much more predictive than it ever has a chance of being. And so it's how do we have those discussions that make those expectations realistic, and that bed the genetic component into also looking at risk factors for non-genetic factors. So looking at the whole picture rather than focusing on genetics. I want to pick up on two things that Rahib already mentioned one of them, but so far, polygenic risk scores are rather skewed in that they are based on genome-wide association studies, and roughly 95% of all genome-wide association study participants are of Northern European ancestry. So where polygenic risk scores do work, they work better in people of Northern European ancestry, and their predictive accuracy is worse for people from other ancestries. And that really needs urgent attention, because at the moment, that diversity, despite people calling for better diversity in genetics as a whole, but also in polygenic risk scores, that hasn't really been translated into more diverse scores yet. And then my other point is a bit more of a philosophical one, I suppose, but as the effects of climate change are becoming ever more visible, we have to realise the carbon footprint of doing significant or genetic testing at scale. So I think we need to think whether the environmental costs are sufficiently offset by the clinical and other benefits of polygenic risk scores. And that might be the case if for example, we can demonstrate that the waste from certain manufacturers of medicines can be avoided through their use. But I think that hasn't really been looked at so far. And there's been a very understandable enthusiasm about translating massive developments in technology into practice. But the environmental sustainability angle of it now needs urgent attention as well.
Great, thank you. So for the audience, get your thinking caps on. I'll be going to for a moment. I just want to bring out some things here first up. So Claire, I thought you made a really good distinction between the kind of risk score aspect and the intervention aspect. And you know, my naive view at some level is that they're rather orthogonal questions, which is how well can you rank someone's risk, and then how well can you intervene? There may be some situations where you absolutely can rank people by risk, but you have nothing you can do by intervention wise, and sort of vice versa. You have interventions, but you're hopeless at ranking people's risk. So is it fair to kind of separate these two things out?
But I think you need to think, but both of them need to be effective, or each of them needs to be effective in order to use it. So if you have a really excellent screening test that's cheap, sensitive, specific, and makes a substantial difference in survival, you probably want to use that in as many people as possible. If you have a screening test that's poor in terms of sensitivity for specificity, or a screening test disease combination where the screening test does not predict natural history very well. So prostate cancer is the classic example, and that's why even the Americans have rolled back on their recommendations around PSA screening, because the prevalence of indolent prostate cancer is so high that your trade-off of the prostate cancers you detect, the aggressive lethal ones versus the indolent ones that you didn't want to find, that is not PSA is not a sensitive test for distinguishing between those. So PSA is not a great test, and it's not a great test if you use it in a high risk slice or you use it in men in general. I think given that PRS are of quite limited predictive value, they do dial up. They'll if you if you take a top 20% or a top 50%, they'll dial up. You'll get a higher than 20% or 50% incidence in that group, but it's not a dramatic enrichment. But the logic would be you use that if you've got an intervention which is really good but very expensive, or has a deleterious side effect profile. So it's really worth tweaking, fine-tuning who you're going to give it to, using dialing up on the risk. That would be my logic of where PRS would be useful.
But my feeling is, and I'll ask Peter's view on this. So presumably, just Claire, you know, so at the moment, the way Q-risk is used for statin prescription is a reasonable use of risk prediction with a reasonable intervention, right? It's a you know, I'm sure I'm not going to go into the details of the current way we do cardiovascular risk and statin prescription, but it's a reasonable slice way through that space. Yeah.
I'd bounce to Arun immediately on that.
Arun, are you happy with the way Q-risk is constructed, as it were?
Well, I think a bit of context is important here. Risk prediction in cardiovascular disease was introduced at the time that statins first came to market, and it was introduced because they were expensive and long-term safety was uncertain. And
Arun, we've got dreadful audio. Is that just me? Okay, that Claire, was that you? Okay.
Can you hear me all right?
No, it's still really. Okay.
Shall I try again? Can you hear me?
Yeah, that's better.
Okay, so risk prediction was introduced at the time statins first came to market, because as Claire mentioned, they were a preventative intervention at the time that was costly because they were patented and we didn't know their long-term safety. So it was logical to target their use to people at highest risk. Now, over time, the guideline groups have reduced the risk threshold at which statins are recommended. Statins have come off patent, so they're affordable, they're very effective, and they're very safe. So the time has actually come now for more prevention and less prediction. We should be doing less in the way of restricting who receives a statin and more in the way of allowing more people access to them. And one way of doing that is with an age-only risk threshold rather than anything like a Q risk measure or even a polygenic risk score. And
why not?
We prevent more events that way.
Okay. But if you're going to set a threshold, why not use all the information that you have at hand?
Because it's simpler and more effective in terms of the number of events prevented to simply offer statins to people once they cross a certain age, an age at which cardiovascular events become common. So 50 would be one proposal. And this has been outlined in a series of polypill papers, which Nick Wall presented in the BMJ over 20 years ago.
So, well, but Peter, I find this Paul, you've got your hand up. Paul, go for it.
Well, I just want to disagree that just using an age threshold results in the prevention of more. I mean, that's just, I'm going to say it's facile, because if you are going to do anything based on risk, then the risk threshold should be based on all possible factors. I agree that it might be simpler and easier to implement when you just base it on age. It would be simpler just to base it on sex and say, actually, we're only going to give these things to men because they're at higher risk. Making something simpler may be the right thing to do, but I think it is wrong to say it prevents more. That is simply not true.
Except to say that age is the overarching contributor to the Q-risk model and most risk prediction models, and actually you gain very little additional risk prediction from adding the other variables.
So let's bring Peter in, because I know, Peter, the trial that you mentioned focused on this specifically. Peter? Yeah? Has he dropped off? Peter, you're muted. Peter, you're muted.
Sorry, sorry, I was just saying on the discussion we've just had, I completely agree with Paul that if one's to use risk as a threshold, we should do that as well as we can. But on the substantive point, there's a kind of interesting perspective. In many aspects of medicine, and cardiovascular risk is one of them, in much of the world, not just in the UK, absolutely standard practice is to estimate individuals' risk and on the basis of that to make recommendations about management. Arun's position is that's the wrong approach. What we're currently doing is the wrong approach, and we should do something different. I'm sort of addressing a different question, and we focus on a different question, which is, well, this is what we are doing, not just here, it's what's done in the US, it's what's done in many other countries. If we're doing it, could we do it better if we included genetics? And as I said, 3 tests, what would you do exactly? Is it practicable and is it cost effective? They're the things we need to understand. Specifically for cardiovascular disease, so heart disease and stroke, as I said, genetics is known to be a major risk factor. We're already estimating risk. Actually, the impact of genetics varies with the relative importance of the genetic risk factor varies with people's age. As an example, if you look at men who are between 45 and 55, their genetic component of risk via the polygenic risk score captures as much risk by itself as all of the other risk factors we combine in the tool Q risk. So it's a substantial component of risk. If we could measure it, it will improve risk prediction. That's been well documented. As I mentioned earlier, and you alluded to, Ewan, we did a trial in the Northeast with GPs. They do the standard risk prediction. We got genetic data from consenting individuals in the trial. We calculated the genetic component of risk. We fed back to the GP both the original risk based on the clinical risk factors and what we call the integrated risk when you add in genetics. 90% of the GPs said it fitted in with their standard workflows. 98.5% of the participants said they found it helpful. So there had been legitimate worries about whether GPs would cope and whether individuals would cope, but both those things were very positive in the trial. And in 13% of the individuals, the GPs changed their management of the patients. So it actually made a difference. Clinically, both for individuals who were previously below the threshold at which statins would be recommended, but actually they said some of the really interesting uses they found were individuals who the current prediction thought had risk of 10 or 12 or so percent, but actually because of the genetic component of risk, their risk might have been over 30%. And that really changed the way the GP thought about managing the patient's risk, and also it changed the patient's view about what they should do, both in terms of lifestyle and statins.
Annika, you want to come in?
Yeah, I think that's a really useful question to say, could we do it better? And I think we need to answer that question, but in answering that question, we need to bear in the other factors of what are the costs of things that we often don't think about, like false positives and subsequent costs to the health service of screening people who end up not being at high risk or not developing the condition in question, and the cost of reassuring people who are at low polygenic risk who go on to develop the disease, as well as the two things I mentioned earlier, the cost of to the environment of doing something that may only have marginal extra value for a quite significant environmental impact, and the cost of providing benefit for a small section of society because it's tailored to help those of particular ancestry and not others, certainly currently.
Claire?
I mean, I think essentially we're in violent agreement about the principles, but differ in our perception of that trade-off. So clearly the polygenic scores will add a little bit more to the risk prediction, as debated by Peter, Paul and Arun. But it's whether what they add is worth the infrastructure that's required, the cost, the complex, scoring and systems that are required, and then the issues around public communication of the data, understanding, consenting, the monetary costs of performing the test, how and where you store that data, how it's funneled into the right place, the fact that some swathes of society may be put off engaging in screening by virtue of having had to have genetic profiling as a prerequisite. There'll be misperceptions around risk and what it means by both medical professionals, also by patients. Will patients who have been told that they're genetically below a risk threshold, will it alter their behavior? Will they stop preventative measures? Will they not present with symptoms? So there's a whole package. And as Annika said, the issue around the ancestry bias, which is a significant issue in the whole field. So there's a whole package of negatives, as it were, of costs, both financial and other, and then there's some benefits. So I think the debate we're having is whether the benefit warrants the costs.
Yeah. So Raki, I'm going to bring you in a moment, but I do note, many of those things were conceptual things that we didn't know whether we could or couldn't do, and now have become less conceptual. They're more concrete, that many of these things are doable, be it here in the UK, be it through things like GEL or Our Future Health, GEL with a clinical view, Our Future Health with a research view, or be it Estonia or Finland or Denmark or Norway. So there are many places that can execute this with reasonable abilities.
I would challenge, have you been to your GP recently, Ewan? Have they really got capacity? This notion that we can just weave this all into our healthcare system.
Yeah, so that's, but
you can technically generate some PRS, integrating them into stratified screening, and particularly the notion that Mrs. Jones is going to start screening at age 47 and have it 2 yearly, Mrs. Smith at age 50 and have it 4 yearly. I think that is a not insubstantial undertaking which is non-trivial, and that's totally different from a research-funded GP practice engaging in a small-scale study.
So, to be fair to Peter and to Samueli in Finland, people have been doing this in practice with real people and real GPs, again, in a research setting. And to be fair to Tomo and his colleagues in Estonia, they're doing it 20% across Estonia. So I don't think it's, I mean, there's a broader piece of health economics, which isn't this topic, but I don't think that is a magic way of getting at these questions. Rakib.
Thanks. So I was going to come in after Claire because she raised many questions and very valid questions, which again, coming back to the point of why our future health has been established, or one of the reasons it's been established, is to be able to answer those questions at a population level. And it's a very large study, of course, but we need to establish clinical utility as well as cost effectiveness in this population before it is rolled out to the whole of the NHS, whether it's impact on primary care for things like diabetes and heart disease, or impact on screening services for breast cancer, colorectal cancer, etc. And that's why our future health is a partnership between working with the NHS when we come to look at these questions, but also working with government and industry to work together to develop the research protocols that can help to answer these types of questions. The only other point I was going to make in terms of clarification, so people that join our future health, everyone who joins consents to having their genotype array done, and we will be able to generate polygenic risk scores for a number of diseases on that, but they will have to reconsent to receive information about their risk of disease, and we will be providing integrated risk scores within a research kind of protocol for these diseases going forward. So it's not that they'll receive this information without having all the information required upfront before they receive that information. So it's just to clarify that point.
Okay, we've got the start of questions coming in, and I'm going to go to Peter and Paul, and then go to some of the questions. Though the first question is more of a comment, but still, Peter.
Thanks, Ewan. So I just want to push back a little bit. Claire's implied a couple of times that polygenic risk scores actually don't make much difference to our understanding of risk. Let me try and tackle that in a couple of ways. One of them, as I said, for heart disease, for men between 45 and 55, it's as important by itself as all the risk factors we currently use put together. For some diseases, that captures a large proportion of the heritability. For others, it's not trivial and it's growing. For some diseases, if you have a high PRS, say in the top 5%, you'd be more than 4 times more likely to get the disease than others. And if you compare people with high polygenic risk score to low polygenic risk score, for some diseases like prostate cancer, that's 40-fold. For heart disease, it's 20-fold. For diabetes, it's 30-fold. So it's not that these things are tiny. And I'll give one example, which I think is quite helpful, and it comes back to the very first point you made. There's a condition called familial hypercholesterolemia. Individuals with that condition have mutations in a small number of genes, and they're the kinds of mutations you talked about, which have big impact. So those individuals have very high cholesterol, and as a consequence, they have substantially increased risk of heart disease, and in particular, early heart disease. And absolutely rightly, health systems and clinical geneticists are very focused on trying to identify those people so they can get the right treatment at the right stage of their lives. Those individuals make up about 1 in 100, or lower than that, 1 in 200 or so of the population. So it's rare. You can ask the question, so that's one kind of genetic risk, people who have these mutations that individually have a big impact. You can ask the question, well, if you have the other type of genetic risk, all of these changes you were talking about that have tiny impacts individually, but you just have more of the ones that are unhelpful. It turns out that about 8% of the population are at the same level of risk because of their polygenic risk as the 1 in 200 individuals who have familial hypercholesterolemia. So they're the same level of risk. They're both sources. The risk comes from genetics in both cases. We work really hard, as indeed we should, to identify and treat the high pathogenic generated risk individuals. But those other individuals, the ones with high polygenic risk, they're responsible for about 20 times more heart attacks in people under 50. And it's very hard to argue that we should concentrate on one type of genetic risk and act, which indeed we should, and then not worry about the others.
Great, Peter. Paul, I want to get some time with the audience, so we're going to have to be quicker now.
All right, well, I'll be very brief. I just wanted to say that we need to remember that when we're thinking about polygenic risk scores in general, there's actually a relatively small number of disease phenotypes that we're really talking about here, because although we've been very successful in the genetics of common diseases, there's not many of them where you'd be thinking about using them clinically, and I could probably list them: heart disease, breast cancer, prostate cancer, colorectal cancer. I'm kind of running out of diseases now that might be useful. And I'm not going to say anything more about heart disease, but in the cancer field, I mean, there's a lot of talk here around using polygenic risk scores in mammographic screening programs. I think there are way too many questions, and these are questions that are not going to be answered by our future health or all of us in the UK, because they are around the interaction between risk and the intervention. You know, that understanding that interface between the intervention and risk pretty much comes down to needing to do randomized controlled trials of the intervention stratified by risk. And that is a phenomenally difficult task. You know, we can't even agree who benefits from mammography in general. Doing randomized controlled trials stratified by risk of mammography, I argued for this 10 years ago, and it could have been done 10 years ago. I think it's never going to happen. And so there are huge problems here. And I think, you know, the general discussion is one thing. I think there's potentially room for polygenic risk scores in cardiovascular disease, but there's a long, long way to go in cancer and other phenotypes. Right.
And Arun.
3 quick points. In terms of the effort and cost, we estimated in the BMJ paper that adding a polygenic risk score to Q risk would involve genotyping an additional 5,000 or 8,000 to 8,000 people to prevent one additional event. The gradients of risk that Peter discussed, they're equivalent to a detection rate or sensitivity of 12% for a 5% false positive rate, a likelihood ratio of 2, which represents pretty poor screening. 88% of later cases missed. And benchmarking polygenic risk scores against other cardiovascular risk factors like blood pressure, cholesterol is often done, but they are also poor screening tests, detection rate of about 12% for a 5% false positive rate. So it's benchmarking one poor screening test against another.
One well-used poor screening test against another. So some comments here. Annika and Mike, you've been agreeing about talking about the carbon cost. I wonder, Mike, whether you would like to just voice what you put in the chat there.
Sure. Apologies. I'm just back from my unit's Christmas lunch, so I've got my Christmas sweater on. Mm-hmm. Thanks, Annika. I just wanted to address your comments about the environmental costs, just essentially stating that calculating a polygenic score for an individual is essentially a negligible CO2 equivalent. We've done that calculation a lot, and it is essentially not much at all.
Once you've done the genotyping, you mean?
It's the genotyping, so you know, I guess the impacts of the construction and running of the array, and that sort of thing, which we don't really have a handle on. But I assume that that wouldn't be too difficult to estimate. But I do think, though, that the scaling part of it, of, you know, one array and then multiple PGSs, you know, it may not end up being much of a concern, to be honest, but we should estimate it. I agree.
So that's, and then Claire, let me just do you have a point that you is it an old point or a new point, or should I go to more questions? Right, to Claire, come back.
It's a very quick point back to Peter's comment on monogenic disease. And I don't want to, Arun obviously is the best person. but a polygenic score for cholesterol seems to be, I'd have thought, superseded by a cholesterol test. Point one, but also this sort of lining up monogenic disease and polygenic disease, that a BRCA pathogenic variant mutation gives you information about the breast cancer risk and also the ovarian cancer risk. So that has double utility, but also you can then cascade in families. So that's one of the sort of, when you undertake analysis for monogenic disease, you have your proband, but you also have added value because you're finding not only one person at high risk, you're finding a whole family. So I always think that sometimes is forgotten when this sort of equivalency argument around the utility. And for most distributions, to genuinely attain that quasi-Mendelian risk, that tiny slice, it's the upper centile or whatever, it's a very, very small number who are at, for example, for breast cancer, a BRCA equivalent risk on the basis of their polygenic score. You don't get the ovarian cancer risk and you don't get the familial opportunity.
Peter, you clearly want to come back in, but I want to reserve some time here. So Peter, nice and quick. Are you muted, Peter? Peter, you're muted.
Muted again, Peter.
Yeah, sorry. I don't disagree with Claire, and I'm absolutely not suggesting we shouldn't do all the amazing things that are done in the UK by clinical geneticists and the Clinical Genetics Service and Genomic Medicine Service in the NHS. A couple of quick comments. You can learn about 2 diseases from BRCA mutations. You can learn about many, many different diseases from getting the genetic data for polygenic risk scores. So there are benefits in each direction in each case. And just to go back to Arun's point that polygenic risk scores are poor screening tests, no one I know of has sensibly suggested using a polygenic risk score as a screening test. Polygenic risk scores are risk factors. And where we're using other risk factors, we should think hard about whether to use them. I completely agree with all the comments that it's complicated. I absolutely agree that in the case of the cancers, there are a whole bunch of complex issues that need careful thought.
Now, David Hunn, I thought you made a very nice comment in the chat, and maybe you'd like to voice that here.
So I'm going to leave that comment in the chat because you can read it. Thank you. But it's about swings and roundabouts. And, you know, as we've heard here, with each use case, both the PRS predictive value added to current available risk factors changes and the intervention changes. So you're always going to have a different opinion. And as Arun has pointed out, the intervention can change over time as statins went from expensive to less expensive. My quick thing I just want to throw in, there are swings. So if you look at who's on a statin in the UK and you look at their cholesterol in that statin, the PRS for LDL cholesterol still predicts people who are inadequately controlled. Ditto, the PRS for blood pressure predicts people who are inadequately controlled on antihypertensives. That shouldn't be the case. You know, those medications should be titrated against the biomarker or blood pressure, but it just doesn't happen in practice. So that's the swing. The roundabout is, it's very disturbing that if I take, let's say, Peter's PRS for a particular condition and Mike's PRS for the same condition, often coming from the same database, I will get a polygenic risk score that might only correlate at like 0.65 or 0.7. And so that tells you that the prediction that Peter would give me could be very different than the prediction that Mike would give me. So we really have to solve this problem because I think that is a major issue. Nobody wants to be told they're in the top 1% in 2024, and then in 2025, well, we've done a calculation differently, and actually you're only in the top 10%. So that's something that I think is an elephant in the room that's inadequately addressed. Thank you.
Okay, thank you very much, David. I didn't realize you were David Hunter, but no idea. Now looking down the questions here, I can see some agreement about colorectal cancer screening. And Richard, would you like to just again voice your opinion out here?
Well, I think Claire said it articulated earlier. that if you have a very good screening tool that's easy to apply, then you might as well use it in the general population. The bulk of disease won't occur in the people with a high polygenic risk score. And in fact, indeed, for the discrimination afforded by polygenic risk scores in colorectal cancer is not very good, okay, right? So there's no real advantage in doing it. So mostly a bulk of the disease occurs in non-susceptible individual people. So you might as well just use it, apply the test, which is actually quite good to the general population. There's no real advantage. And so also I'd like to bring in one of the things which I'm slightly concerned about in the discussion is that it really does tend to focus on cardiovascular disease as an example of polygenic risk score for all diseases. And for many diseases, the change in absolute risk is so minimal, okay, right, clinically between the top and bottom, that it's actually practically clinically very limited value, okay. And that's basically negates the point about the PRS. When you use an array, you can harvest lots of diseases. The idea for most cancers, there's either nothing you can do about it, or the difference in polygenic risk, the difference in absolute risk between the top, middle, or bottom of the percentile is very, very minimal. So let's say like say renal cancer, there's no real, very minimal difference, okay, or multiple myeloma, CLL. And I think I can speak to some degree of authoritative on that because I'm guilty of running the international genome screens on all of those cancers. So I think there's really quite a concern about using CVS as an example applied to virtually all these disease states, and clearly there's no advantage of being told you're at a slightly increased risk of developing ocular pressures when you can just have a puff test at the ophthalmologist, especially when it's got very poor discrimination.
So one interesting, I don't know how many people take this perspective on this, which is that we kind of have measurements and then we have ways of combining those measurements. And rather than placing these things into these buckets called screening and risk and other things. And, there's lots of times when we want to do, a kind of appropriate blending of multiple measurements and try to give our best understanding of what is happening in an individual to a clinician. And we can either then have guidelines about what happens next, or it can be kind of clinician's choice. Is there any benefit of trying to not frame this as screening, as it were, but measurement?
No, I don't have an issue about risk, but the point about it is I think for most cancers, the risk factors are quite reasonably well established, and you'd apply those to everyone turning up to outpatients, okay? So I think that's one concern, okay? I don't want to go into cardiovascular because I'm not an expert in the area, but I think the point about cancer is that for most cancers, you'd apply the same, if you have somebody who's grossly obese, you'd recommend they lose weight because it's an risk factor for both colorectal cancer and renal cancer. And from other cancers, like say the hematological ones, we actually know virtually no risk factors that you change, that you can't modify the risks of the person, even if you knew the polygenic risk score with any degree of certainty, which you can't predict based on current PRS tests. So it's very difficult to see how you'd actually use that data that you'd harvest from the array with a lot of other disease states. That's my only concern. I don't personally have an issue about like GWAS or everything, because they're actually informative from an understanding of the biological basis of the disease, but whether they're actually very useful from a clinical translational point of view for many diseases is quite questionable.
Right. So there's a nice chat going on here between on the chat about, again, the David, about the difference between polygenic scores from different groups. And then this business, so sorry, I'm just keeping track of all of this. Richard making the point that there is the social and behavioral therapy that PRS primary care setting can substantially and sustainably change lifestyle choices by patients. And I think, Peter, I know that, again, your trial, you mentioned that a number of GPs did change their prescribing, and again, channeling my inner Finn, which is Samuel Ripati. I know that a similar thing was found in Finland. Again, it's in the cardiovascular setting. So I do think there is evidence that actually kind of compliance as well as lifestyle is changed when these integrated scores are presented to people. Now, quite why that is an interesting question in itself, I think. So I would like to offer the chance for some final thoughts from people, and maybe would the panel have any final thoughts having heard that discussion? Claire.
I think I wanted to bounce a question across to another panel member. So as Paul said, the key is that you align your risk stratification with your intervention, whatever it is, a screening, a statin, a treatment, whatever. And he had sort of aspirations of doing that in breast cancer. So to Raghib, how you said earlier that that our future health will clarify the clinical utility of PRS. But can you just put a bit more flesh on the bones of where we'll be in 5 or 10 years' time from the outputs of our future health in terms of that understanding?
Sure, thanks, Claire. I mean, it does depend on the disease as to what the research question will be. And our future health is not a study of polygenic risk scores. It's, as I said, we're creating a resource to answer all sorts of research questions, one of which could be looking at the utility of, well, mainly integrated risk scores in different diseases. So you could, for example, in cardiovascular disease, run a randomized control trial looking at using an integrated risk score with the addition of polygenic component onto the traditional risk score, and in different age groups and different ethnic groups, and we will have sufficient numbers to look at that. Paul said it's not possible in breast cancer screening because it's a very big trial to do, although again we would have millions of women in the study who would have this information where again we could look, I think, although we'd have to work with people in the field to understand the best study design for that, but working with the screening services again to see whether this approach has both clinical utility and cost effectiveness. So randomized controlled trials, of course, are going to give us the best evidence, but there are other study designs, quasi-experimental designs as well, that we could use. But one other point I wanted to raise, because I know we're almost out of time, is also in terms of identifying people at higher risk and the approach for not just screening or pharmacological intervention, but also non-pharmacological intervention. So we've had some evidence, although I would say it's limited outside of certain age groups and certain ethnic groups, as to whether identifying people at higher risk and giving them that information, not just based on genetic risk, but all risk factors, does lead to changes. I mean, for diabetes, for example, South Asians are at higher risk, but there haven't been large studies or really any studies done in that population of younger people to see whether having that information will lead to changes in what are known to be the risk factors for diabetes in terms of physical activity, unhealthy diet, etc. So these are other questions that we can answer. I mean, our future health is looking primarily at prevention and early detection and interventions that will lead to better outcomes, but it is disease specific as to what that research question will be.
Right. So we're closing it up. I'm just looking around whether anybody else would like to come in. If not, I can confidently predict that there will still be a debate about polygenic risk scores in 5 years' time. But we will have that debate with yet more data and yet more experience, I think, in different areas. And as ever in these discussions, I think the interesting thing is not only where we debate and disagree, but what is the implicit agreement by everybody around the table. And so that is always sort of reassuring. That's the way I mark progress, is the things that scientists don't argue about. Thank you very much to the panel, and thank you for the questions there. And I hope you all have a very good evening.